Thought, well, somebody who's living with a long-term condition, we worked out it's about 6 hours. That's a long time for the rest of the year when people are actually going to be needing to make decisions about their own health care, be supported by informal carers, supported by themselves. So of that 15 million people that we know live with at least one long-term condition, we're very keen to make sure that they have the opportunities to make those decisions for themselves and to be supported in a way which will end up improving the way that they live their lives rather than being dominated by the health problems that they live with. And as you can see from some of the numbers I put up there, we know that these conditions account for a lot of the hospital use, a lot of the GP time, a lot of the outpatient appointments. We also know that it takes up a lot of the social care time. And it's about 70% of the total health and social care spend. So we have a model. We have a model to manage long-term conditions within this country. And it's based on an internationally renowned model which started in the 90s. A chap called Ed Wagner in the States talked about chronic care and the chronic care model. But we didn't want to just adopt it wholeheartedly and say, well, it'll work here. What we wanted to do was understand how this is going to impact in England. And I know we're here talking about telehealth and telecare, but I wanted to really just remind ourselves that this isn't about technology. This is about people. This is about the way that people live their lives. And this is about how we organise care to support people to make decisions and be able to live a life in the way that they want to live rather than being dominated by the health that they have. And what is the difference between a stethoscope and telehealth? They both transmit data from one person to another. So what is the difference? It's distance. It's the ability to do that remotely. You really start to appreciate what's going on in the world when you think forward. But just think back as well. 20 years ago, what was happening? So what could be the potential changes in 20 years' time? And basically what he's saying is that people who are not in positions of decision-making now, so young people, they are going to be in positions of power and authority in the future. And they're not going to be worrying about whether or not this technology works. This is the sort of generation that is coming up behind us all. So it isn't going to be a case of if and what, it's when and how. So this is the slide that I use quite a lot. And this is about just exactly that point. People will want to live their lives. They will want to use the technology. They won't be wondering about it. They'll just do it. Back in 2006, we were having, back in the department, conversations around very similar sort of topics that we're having today. What is this technology? How does it work? Is it worth it? Does it make a difference? And there's an awful, even by 2006, there was an awful lot of evidence and studies had been done which suggested that there was something in the use of this technology. If you used it, people tended to, first of all, they liked it, the satisfaction levels were high, but they tended to be able to avoid unnecessary and unplanned admissions to hospital. They tended to be able to not spend as much time in accident emergency departments, and they tended to be able to have access to better care and better outcomes. The question, though, back in 2006 is can that be relied upon? Because a lot of that evidence, and subsequently since then, has been small-scale studies. That's why we set up a whole system demonstrator program, and that's why I'm very appreciative of the hard work and efforts that went into it in Kent. It wasn't easy. We had to recruit not just 10 times more, but almost 20 times more than a lot of other studies have recruited to do this. The design of the study took nearly 2 years. The power calculations to make sure that we got the confidence in the results took a long time to work through. But in the end, we got across the 3 sites and across the telehealth and telecare spectrum over 6,000 people involved. It was about 6,190 something. I can't remember the exact number now. And that was including a number of informal carers as well. And they were split fairly equally across the sites, fairly equally across telehealth and telecare. But the biggest single difficulty in all of this was not the enthusiasm, was not trying to find the sites, was actually recruiting people. And that's not because people didn't want to do it, but because of the design of the study. It was so rigorously designed and had to be followed as part of the ethics approval for it to be academically sound, that, for example, the first thing that you could do when you contacted the patient or the potential user was a letter saying, are you prepared for us to share your data with health and social care? And I am amazed at how many people came back and said, yes, I'm quite interested to see what this is about. The results that we've been able to release so far are merely the headlines on Telehealth. And the reason for that is very straightforward. It took us longer to recruit than we expected. The data then had to flow through to the independent evaluation team. That evaluation team got the data, I think, January, February last year. There were millions of records for them to process. And we particularly said we want to know as quickly as you possibly can what's happening around the telehealth world, what's happening in those areas. And this is what's come out. You can see on the screen there, the emergency admissions fell by 20%. And that's the difference between the control group and the intervention group. So those using it and those getting normal care. The telecare findings, not far behind. They are working on those now. I can't say what they are because I haven't seen it. I really don't know. But if it's like any other study that I've seen on telehealth and telecare, we should be expecting to see some difference between intervention and control groups. What we haven't yet got is the full breakdown on the 3 sites, the full breakdown on the conditions which were trialled in the study, which were coronary heart disease, diabetes and COPD. That's being worked on. I've seen some of the early thoughts on that and some of the way that they've been cutting the data, and it's going along the same sort of lines, but we haven't got anything yet to share. Now, I make no apologies for putting out the headlines, because it's taken longer to get the full recruitment. It took longer for us to get the full papers. The papers, though, are going to be published through peer review in a peer review journal. The BMJ is where we're trying to put them. And this will give this study authority. And that's where we can say we've put piloting to bed. The issue, though, is I saw these numbers quite some time ago, and we had to make a decision. Do we just wait until it all goes through the process, which is, you know, an academic process, rather than a policy development or a service delivery process? And I waited and waited, and I took the decision that we couldn't wait any longer. These just needed to be aired. People needed to see this. And I know there's lots of questions behind it. What's the detail? What's the data? Etc. But these are the headlines that we've got. Now, this is quite interesting for me because the 45% reduction in mortality is something which I wasn't expecting. But the 20% reduction in emergency admissions, that is actually, I think, really promising result. If you look at the studies that have been done elsewhere over the years, emergency admissions using telehealth tend to reduce by between about 35–40%, anything up to about 80–85%. And it depends on the size of the study, the numbers of people you involve, over what period, etc. So for a better quality of outcome, better quality of care, you're getting a similar quality of life. That's very important. I think it dispels the myth that if you use remote intervention, you get isolation, you get people concerned, you get people having a poorer quality of life. And I think delivery can be achieved, but it can only be achieved at scale. Why don't we all work together to see if there really is a market here, if there is, how it works, if it works, what were the results that could make a difference. Oh, and by the way, to do it, you've got to get some economies of scale. So to do that, you've got to really reduce your price point, i.e. get it down from that £1,500 a mark down to, well, very low. And the reason you can do that is you think about the technology that I mentioned before, the sort of things that we use every day. Very few of us go out and buy these things. We get it on some sort of, you know, pay-as-you-go or maintenance agreement or whatever. That's the model that we should be looking for. And the return could be through a revenue stream rather than a capital stream. It has been seen for too long that telehealth and telecare is a capital-driven market. It isn't. It should be a revenue-driven market. So as patients are using it, you start getting an income. Simple. If they don't use it, you don't get an income. There's a risk. Absolutely. There's a risk that you might invest as an industry in a lot of this and nobody uses it. the proposal that we're trying to build through this 3 million lives work is that you share that risk. The health and social care providers could pay a large revenue stream, or they could pay a low revenue stream. And if you go for a low revenue stream, maybe what you do is, as you make savings down the line because you're not admitting people to hospital, and if you can turn that into cash, you get that money out of the hospital, share that with the people you've got contracts with. So you've got to mix and match and think about that contractual arrangement. And we've been buying for too long on the basis of the people with the money, the commissioners, getting the equipment from the industry people, and then commissioning a service from the health or social care people, and then trying to put the two together. That doesn't work. What you need to do as a commissioner is you need a service. You need the industry, the providers of the equipment and the providers of the healthcare and social care to come together, design a service of which there is a cost. And that's how we should do it. It's exactly the model that we've used elsewhere. You don't, as a commissioner, purchase healthcare from a hospital, then purchase the machine that goes ping and say, put it in the hospital, please. It doesn't work like that. And it's a tried and tested model that's been going on for years, and we should be doing it in the community health system as well. So that's what 3 million lives is about. It's about changing the environment. It's about creating the movement, allowing people to see opportunities, design services for people, not worrying about whether this kit is the thing that I need to buy. It's what service do people need, and then designing it appropriately. And what we've been asking from the industry people, and they are working with us on this, is instead of trying to come up with 25 different ways of doing this, trying to come up with a simple proposition which is then offered to health and social care commissioners. And if there's a simple proposition along the lines that I've just talked about, then you can start to see how this makes a bit more sense. With telehealth and telecare and improving care for people with long-term conditions, we can change this, we can make it more convenient. And that is essentially what the 3 million lives is about. And that's why we want to use the evidence from Whole System Demonstrator as it's coming out to drive that change, drive that movement, get people engaged in the way that they want to deliver care. But think about how you then overlay the technology on to those new services for the benefit of the people that are using them.